Welcome back to Podocyte Talk. In this episode, we're exploring 3 timely and clinically relevant studies that shed light on real-world questions in nephrology. What's the ideal blood pressure target after a kidney transplant? Should we stop SGLT2 inhibitors before coronary angiography? And what do blood sugar levels truly look like in people receiving maintenance dialysis? Let's begin with blood pressure management after kidney transplantation. High blood pressure is one of the most common problems in kidney transplant recipients, and it's a well-known risk factor for cardiovascular disease, the leading cause of death in this population. But the ideal blood pressure target post-transplant has remained unclear. To answer this, a large-scale study used data from over 62,000 kidney transplant recipients across 209 centers in 39 countries, analyzing blood pressure at 1 year post-transplant and following outcomes for up to 6 years. The goal was to see how different blood pressure levels, as defined by the American College of Cardiology and American Heart Association guidelines, affected graft survival and patient mortality. The findings were important. Most patients, around 77%, had hypertension at 1 year. When comparing those with normal blood pressure to those with slightly elevated readings, there was no difference in outcomes. However, once blood pressure reached stage 1 or stage 2 hypertension levels, the risk of graft failure increased, particularly in those with more severe hypertension. Mortality was significantly higher in the group with stage 2 hypertension. What's even more striking is that patients who had stage 2 hypertension at 1 year continued to have an increased risk of graft loss, even if their blood pressure improved in the second year. This suggests that early blood pressure control is crucial. Waiting too long may leave lasting damage. So the takeaway from this study is clear. Early and effective management of high blood pressure after kidney transplantation may improve both graft survival and patient outcomes. It's not enough to wait and see. Intervening early really matters. Now let's turn to the second study, the BELIEVE trial, which addresses an increasingly common clinical question. Should SGLT2 inhibitors be withheld before procedures like coronary angiography? SGLT2 inhibitors are now a cornerstone of therapy for type 2 diabetes, chronic kidney disease, and heart failure. But because of concerns about dehydration and contrast-induced acute kidney injury, clinicians often stop these medications before procedures involving contrast dye. The BELIEVE trial was a prospective, multi-center, randomized controlled study designed to examine this very issue. It enrolled 200 patients who had been taking SGLT2 inhibitors for at least 3 months and were scheduled for elective coronary angiography. Participants were randomized to either continue their SGLT2 inhibitors or stop them 72 hours before the procedure, restarting afterward. The main outcome was the incidence of contrast-associated acute kidney injury, along with changes in kidney function and adverse events during hospitalization and over a 90-day follow-up period. The results were reassuring. The incidence of contrast-associated acute kidney injury was very low in both groups, with no significant difference between continuing and withholding the medication. Interestingly, kidney function appeared slightly more stable in those who continued their SGLT2 inhibitors, though the difference was small. There was one case of diabetic ketoacidosis in the group that continued therapy, reminding us that this is a rare but serious potential side effect. Overall, the trial suggests that for stable, low-risk patients, continuing SGLT2 inhibitors during the peri-procedural period may be safe and doesn't increase the risk of kidney injury. Routine discontinuation may not be necessary, though individualized decisions are still important depending on the patient's overall condition and risk factors. And now to the third and final study of this episode, a closer look at glucose control in people on dialysis using continuous glucose monitoring, CGM. Managing diabetes in patients with kidney failure is especially challenging. Traditional markers like hemoglobin A1C can be unreliable, and dialysis itself affects glucose levels. To better understand this, researchers conducted a prospective study using CGM in a large, diverse group of 420 patients receiving maintenance dialysis. Each participant wore a CGM device for about 10 days, capturing real-time glucose readings. The study included patients with diabetes, some treated and some untreated, as well as people without diabetes. It also looked at differences between those on hemodialysis and those on peritoneal dialysis. The findings were eye-opening. Among patients without diabetes, blood glucose levels were still higher in those on peritoneal dialysis compared to hemodialysis. And even though these patients weren't being treated for diabetes, they experienced frequent episodes of hypoglycemia, low blood sugar, that likely would have gone unnoticed without CGM. For patients with diabetes who weren't taking glucose-lowering medications, blood sugars still showed a diabetic pattern, with many not meeting typical targets for time and range. And among patients who were actively treated for diabetes, glucose levels were often very high, and only a small portion met modern CGM-based targets. Despite what looked like decent A1C levels, CGM revealed a high burden of both hyperglycemia and hypoglycemia in these patients. What does this mean for clinical care? It suggests that our usual tools may be missing a lot. Hemodialysis and peritoneal dialysis patients, whether or not they have diabetes, can have significant glucose fluctuations, and these fluctuations may not be evident with standard testing. CGM provides a clearer picture and may help tailor diabetes management in this vulnerable population. In summary, these 3 studies offer valuable guidance across different aspects of nephrology care. Blood pressure should be managed proactively and aggressively after kidney transplant to reduce long-term risks. SGLT2 inhibitors may not need to be routinely stopped before coronary angiography, especially in stable patients. And CGM can uncover important and often hidden glycemic patterns in people on dialysis, challenging us to think beyond A1C when managing diabetes in this group. Thanks for tuning in to Podocyte Talk. Be sure to check the description for links to all 3 studies. And stay with us each week for more evidence-based updates and insights in kidney disease and clinical practice.